It's my absolute pleasure to welcome you to this first Uro-neurology Academy webinar, and also to welcome you to the launch of the Uro-neurology Academy. I have a very expert speaker based with me, so we're hoping that we've got a really interesting 75 minutes. So we have extended the programme just slightly. We had quite a bit to include. So just to introduce you to the faculty, my name is Ruth Stross. I'm Head of Nursing with Neurology Academy. I have a background as a neurology nurse and as an MS and Parkinson's specialist nurse. With me today is Professor Jalesh Panikkar, who is our academic director for this Uro-neurology Academy. He's also a consultant neurology in Uro-neurology at the UCLH in London. With me is also Colette Haslam, clinical nurse specialist in Uro-neurology at the National, and also Stu Thomas, who is an independent healthcare consultant and also sits on NHS England CRG for neurosciences. So just to let you know what we're going to cover today, obviously within a very short period of time, we are hoping to go through a very basic approach to managing urinary incontinence in a neurological patient. We have a really a very much up-to-date overview of NHS England and NHS Improvement, the Neuroscience Transformation Programme from Stu Thomas, which will help look at the implications for MS and urology services and across neurology. So the agenda, what we will be covering is, obviously, I will present a case study. We very much like to go with that way of setting the webinar, because that's around personal experience. Then Professor Panikkar will look at the medical approach and management. Colette will be going through the conservative management, Sue the transformation agenda, and there will be time for Q&A. So we would really encourage you, please, to put the questions in, and then when we get to that phase, we can actually go through them. If we're unable to answer them, then we can decide later on as to how we will manage that. So for the case study, so to set the scene, we've very much wanted to bring up someone that obviously you will have potentially looked at within your own areas, and someone that brings that kind of the whole of the education that we will be presenting much closer to home. So this is a 33-year-old female with relapsing remitting MS. She was diagnosed 8 years ago. She's a primary school teacher. She is married with 2 young children. Her EDSS at the moment is 2. She is on a disease-modifying therapy, Tecfidera. She had a relapse 3 years ago, which left her with urgency, increased daytime frequency, and she's up 3 times during the night with nocturia. And she's also mentioning during the clinic appointment that she is struggling with incontinence. So as of this particular, this was in the current state at the moment, she is finding that is worse. She's experiencing hesitancy and interrupted stream. She has occasional urinary tract infections, and she has noticed change to sexual sensation and also constipation. So it's my absolute pleasure to introduce you to Professor Panikkar. As I mentioned, he works at the National, and he will be covering medical approach and management. Thanks, Jalesh.
Right. So thank you very much, Ruth, for those warm words of introduction. So my name is Jalesh Panikkar, and I'm excited to be here in this webinar. Thank you for joining us this morning. And so I will be taking you through the medical approach and management in the next sort of 15 to 20 minutes. These are my disclosures. And so the case vignette that we heard, sadly, is a common picture that we see following many of the devastating neurological disorders, so spinal cord injury, MS, diabetes, stroke. Well, we can find that the prevalence of neurogenic detrusor overactivity is quite high, and conditions such as MS and spinal cord injury nearing 100%, depending on where the patient is seen during their journey and the extent of neurological injury. But in conditions that we less commonly associate such as in stroke or even Alzheimer's, we find that the prevalences approach 50%. So indeed, a common problem. And the bladder dysfunction has a significant impact on quality of life. This is just the results of a survey of a large cohort of individuals with MS from Australia, published several years ago. Where nearly 70% of patients reported that the impact of bladder problems was classed as moderate or high. What I would also like to highlight here is the fact that amongst the different motor and non-motor symptoms in this cohort of multiple sclerosis, bladder problems fares quite high amongst bladder symptoms. Now, the same is the case in other neurological conditions as well, such as Parkinson's disease. And when validated questionnaires are administered to individuals with Parkinson's, one finds that the non-motor symptoms related to the bladder, such as nocturia and urinary urgency, actually are topmost in terms of symptoms that patients report. And the impact this has on the healthcare system is immense. And studies have shown that bladder problems, specifically urinary tract infections, are the top 3 causes for non-elective admissions in the setting of Parkinson's disease. Now, if we take a step back and try to understand the bladder dysfunction that occurs following neurological disease, from a uro-neurology perspective, we look at conditions that are sort of above the level of the pons and below the level of the pons. So you have sort of suprapontine neurological conditions such as Parkinson's disease, stroke, brain tumors, traumatic brain injury, or neurodegenerative dementias or vascular dementias, where there is a pattern of bladder symptoms and dysfunction that what we find is predominantly that of urinary storage symptoms, such as what we heard in the case vignette of urgency and increased daytime frequency, nocturia, and urgency-related incontinence. The post-void residual volume is usually low, and that's in view of a coordinated contractions of the detrusor and the sphincter, which ensures an efficient emptying of the bladder, and urodynamics will reveal evidence for detrusor overactivity. Now, with an infrapontine suprasacral lesion, so these are essentially your spinal cord lesions, such as with multiple sclerosis or spinal cord injury or spinal cord tumors, we find a slightly different pattern of that of storage problems, but also voiding symptoms as well, which we heard about: urinary hesitancy, an intermittent stream, a sensation of incomplete bladder emptying, double voiding. The post-void residual volume, which is the volume of urine left behind in the bladder after a void, is usually elevated, and urodynamics demonstrates detrusor overactivity, but also a lack of coordination between the detrusor and the sphincter, and this is known as detrusor sphincter dyssynergia. Now, with a sacral cord lesion or an infrasacral lesion, such as an injury to the cauda equina or the peripheral nerves, this can occur in the context of the disc prolapse, for example, with the cauda equina syndrome, a tumor of the conus of the cauda, a pelvic nerve injury, for example, following surgery in the pelvis, or a neuropathy, like a small fiber neuropathy in the context of diabetes, or some of the less common neuropathies, such as amyloid. What we find is a predominant voiding symptom, and post-void residue is usually elevated, and often we find a contractile detrusor picture in urodynamics. Now, these are just rules of thumb, and there are several exceptions, but at the bedside, this is a useful tool to adopt. So if you have a patient that presents on the left-hand side of your screen with an established neurological disease, and you find that there's a pattern of bladder symptom or bladder dysfunction that's sort of incongruent to what you see, what you'd expect, then you should start thinking, well, is there an additional neurological lesion somewhere else? Or is there an additional urological lesion, such as an enlarged prostate, or perhaps stress incontinence in the context of multiparity? One could also approach this from the right-hand side of the screen. So a patient with an unexplained sort of neurological symptoms and with associated urogenital symptoms, where there's still a diagnostic workup happening. And based on the pattern of bladder symptoms and dysfunction, one may be able to localize the lesion and thereby help in the diagnostic formulation. Now, when we consider incontinence in the context of neurological disease, we think about the most common causes for urinary incontinence. One could be from an overactive detrusor, which results in urgency incontinence. Incontinence occurring in the context of a weak pelvic floor, such as with effort or exertion, that we call stress incontinence. Or we have a continuous dribbling incontinence that occurs in the context of chronic urinary retention. And from history and some bedside assessments, one would be able to sort of make out between these three common causes of incontinence. In the context of neurological disease, one may also have incontinence which is related to poor mobility or perhaps poor toilet access because of the poor mobility, what we call functional incontinence. So the patient might have an element of an overactive bladder, a degree of urinary urgency, but because of problems with mobility, or perhaps the toilet is perhaps accessible on the ground floor or the first floor, by the time the patient makes it to the toilet, they become incontinent. Or it may be further a complex pattern of incontinence occurring in the context of cognitive impairment. There may be problems with visual-spatial disorientation. The patient becomes confused where to go when they experience that urge to urinate, or there might be problems with memory where the patient doesn't remember where they need to go or what they need to do if they experience the urge to urinate. Problems with communication, or there could be complex behavioral issues that could predispose to urinary incontinence, particularly in the context of frontal lobe injury or frontotemporal dementias. The neurological disability can also impact bladder dysfunction. And we take, for example, spasticity, where we know that lower limb and pelvic floor spasticity can contribute to difficulties with evacuation of the rectum and the bladder, thereby resulting in voiding dysfunction, urinary retention, and impaired defecation. And it's a bidirectional relationship because we know that in patients who have spasticity, if there is sort of unaddressed bladder and bowel dysfunction, that could worsen the spasticity independent of the neurological disability and neurological injury. So history taking is a cornerstone in a patient that presents. So in this case vignette, we have an elaborate history there. We understand that there are urinary storage problems and urinary voiding problems. We understand that there have been urinary tract infections, and it's not apparent if there are any other possible complications from the neurogenic bladder dysfunction from that history alone. Now, a bladder diary is useful as an extension of history taking. It provides a real-time assessment of the patient's symptoms, which often we find provides a more accurate assessment of the extent and severity of the bladder problems, but also the impact on quality of life. So in the diary, by asking the patient to mark when they pee and what volumes, and when they drink and at what volumes, it gives us an assessment of fluid intake, which then enters a discussion about the types of beverages that we'll hear about from Colette in the next talk, and which can impact bladder symptoms. By knowing when they go to bed at night, when they wake up in the morning, will give us an idea about their nighttime and daytime frequency. By measuring their voided volumes, it gives us a rough idea about their functional bladder capacity. So without any formal urological tests, we have a rough idea about their bladder capacity and how much the bladder may be holding in a real life situation. And also it provides us a more accurate assessment of the degree of urinary incontinence that the patient has. Now, when we assess the urinary tract, patients with neurological disease, it's not just the lower urinary tract we need to think about, but also the risk for developing upper tract damage. Before the advent of intermittent catheterization, the commonest cause of mortality in patients with spinal cord injury was actually renal failure from very high bladder pressures and resulting in renal damage. But what we now know is that there is actually a differences between neurological disorders, and the rule of thumb is that those with a progressive neurological condition, such as multiple sclerosis, the risk for developing upper tract damage is less compared to those who, say, have a static neurological condition, such as spinal cord injury, or a neurological condition that has started in utero, such as a spinal dysraphism, where we find the prevalence of upper tract damage and the risk of renal failure is generally higher, which means that in neurology services that usually more often see patients with progressive neurological conditions, you generally are are dealing with patients who have generally a lower risk for developing upper tract damage. Once again, there are exceptions to this, but it is a general rule of thumb. And as a practitioner who manages the neurogenic bladder, one should just be aware when to seek help from urology colleagues and when to refer early on if you anticipate that this patient may be at greater risk for developing upper tract damage. Now, there are different first-line bedside assessments. This is one that you might be familiar with, where the entry point is the urinary storage symptoms. Urine analysis helps to test for urinary tract infections or to screen for urinary tract infections, and we measure the post-void residual volume. And these are usually the baseline first-line assessments of at the bedside of patients with neurogenic bladder problems. With the post-void residual volume can be measured by either a bedside ultrasound, a handheld ultrasound, a portable device, or in-out catheterization. And it's important to recognize that the post-void residual is high because this having a high PVR can predispose to worsening of storage symptoms, but also stagnant water as a breeding ground for bugs, and can predispose to recurrent UTIs. Now, urodynamics testing is a formal evaluation of urinary functions, tells us about the pressures and the volumes, and tells us about urinary storage and voiding. And it is a useful test to understand the dysfunction that occurs in neurological disease, and is indicated in some patients, but not all. Particularly the ones that we would want to perform urodynamics testing would be those who have a greater risk for upper tract damage, those in whom the bladder symptoms are just unclear from your history taking or from the bladder diary, and those who have a poor response to your first-line conservative or medical management in whom you're considering further interventions. Now, there are different sort of management algorithms, and the first line management involves conservative approaches to managing neurogenic incontinence, which Colette will be taking you through in a few moments. I will be taking you through the different medical managements, and the cornerstone of medical management is oral agents, botulinum toxin, and neuromodulation. So the first-line treatment are antimuscarinic agents, and some of you in this call will recognize these names. There are different antimuscarinic agents, and often the question asked is which one. So there is a systematic review and meta-analysis of the data that has different studies that have shown that in terms of efficacy, there's no difference between these different antimuscarinic agents. The differences are in regards to the side effects. And so you have the older non-selective antimuscarinic agents, such as oxybutynin and propyvarine, which by nature of their non-selectivity, they bind to different muscarinic receptors in the bladder and thereby in the body, and thereby predispose to side effects. And you have the newer antimuscarinic agents, such as solifenacin, fesoterodine, or tolterodine, or trospium chloride, which are more selective for the bladder muscarinic receptors and thereby have less side effects. And what are the side effects that one looks for? Include constipation, dry mouth and dry eyes, voiding difficulties, blurred vision, and tachycardia, and of late concerns about cognition and even delirium. Now, these sort of set of symptoms are often reported by patients with neurological disease, and therefore one must be cautious about starting an antimuscarinic agent to avoid sort of worsening of already existing neurological symptoms. Now, there should be a caution used in starting these medications in individuals who've had an acute coronary event or cardiac failure, those who have a susceptibility for a prolonged QT interval, such as particularly for solifenacin, and there are some GI conditions that one should be cautious about starting antimuscarinics, including hiatus hernia or reflux disease. If an elderly person is already on a medication with an anticholinergic property, such as a tricyclic antidepressant, for example, one should be cautious about introducing one more, because what we're doing is we're increasing the anticholinergic burden and increasing the risk for developing anticholinergic related side effects. We should definitely avoid antimuscarinics in those who have known angle-closure glaucoma, or if they have severe bowel disease, such as ulcerative colitis or GI obstruction. And myasthenia gravis is a relative contraindication for using antimuscarinics. Now, there are different studies that have been published that have shown clearly that these antimuscarinic agents are effective for managing overactive bladder symptoms in the context of neurological disease. This is level 1 evidence based on RCTs and real-world data as well, and it has a grade A recommendations and high-quality guidelines for the use for this purpose. We move on to another oral agent, and that's mirabegron, which belongs to the class of drugs called as beta-3 receptor agonist. So they work through a different receptor in the bladder, and systematic reviews have demonstrated, which have reviewed published data on the use of beta-3 receptor agonists in neurogenic OAB, that these medications are associated with an improvement in bladder compliance, incontinence, and incontinence-related quality of life. The side effects are generally more related to cardiovascular. They include palpitations, arrhythmias, and a rise in blood pressure. One should exercise caution when using these medications if the patient has a prolonged QT interval or if they have high blood pressure. And if their blood pressure exceeds 180 by 110, then actually these medications should be avoided. Moving on to botulinum toxin, this is an agent that's revolutionized the management of neurogenic diffuse overactivity. It's an agent that's been in the field for well over 80 years, but when it comes to urology, it's probably in the last sort of 20 to 25 years. But during this period, there have been 2 pivotal phase 3 trials that have been published, and numerous studies that have, in addition, that have been published in the real world, that have demonstrated safety and efficacy for use of botulinum toxin. This can be delivered either through a flexible cystoscopy, as you can see here, or rigid cystoscopy. If it's flexible cystoscopy, it's a day case procedure. And generally, the licensed dosage is 200 units if botulinum toxin is used, which is injected in 20 or 30 sites with a low discomfort scale, and the effect lasts for around 6 to 10 months. Now, based on the evidence, this has a grade A recommendation for use based on level 1 evidence in high quality guidelines. We move on very briefly on neuromodulation. And so any nerve that has some sacral representation, if stimulated, can have an effect on bladder symptoms. The 2 sort of modes of neuromodulation that are generally used currently is tibial neuromodulation, sacral neuromodulation. And so the nerves that can be stimulated either percutaneously. This is using a 23 gauge acupuncture needle. It's connected to a power source, and generally it's 10 to 20 hertz is the frequency used, with a pulse width around 200 microvolts. And so this is the stimulus that is sort of conventionally delivered intermittently once a week for around 8 to 12 weeks. And tibial nerve stimulation has been shown to be effective not only for management of urinary incontinence, but also fecal incontinence as well. And there have been several open label studies that have shown this treatment to be effective for management of neurogenic urinary incontinence. Transcutaneous tibial nerve stimulation involves using a patch electrode. So essentially, it's a TENS machine that's used, which can deliver the current in with a similar waveform, similar pulse frequency, as it is something that can be sort of applied over the skin, it has the potential for being a sort of a home-based neuromodulation system, which makes it particularly attractive. Once again, there have been at least 2 randomized control trials and numerous smaller studies, observational studies that have shown efficacy and safety of use of TTNS for management of neurogenic incontinence. Now, sacral neuromodulation is more invasive. It involves implanting an implantable programmable generator, basically which is implanted beneath the skin with stimulation of usually the S3 and sometimes the S4 nerve root. A sacral neuromodulation is a highly effective treatment for management of urinary incontinence and non-obstructive urinary retention in the non-neurological population. In the neurological population, the evidence base isn't as strong, but there are several studies that have shown efficacy, and it is a treatment that you will see being used more and more in patients with neurogenic urinary incontinence and possibly avoiding dysfunction as well. Now, there are some red flags, I think, if you are working in a neurology unit that you should be aware of, where patients who should be referred to urology early on. So those are deemed to have a higher risk for upper tract damage, symptoms refractory to first-line treatment, recurrent UTIs, or if you're suspecting a urological pathology, either in the upper or the lower urinary tract. So in conclusion, ask about the bladder symptoms in your neurological patients, because you'll find that more often than not, there will be symptoms which are likely to be impacting their quality of life, that your bedside assessment with a urine analysis and a measurement of post-void residue provides sufficient information to initiate treatment in most of your neurological patients, but not all, because specialist tests may be indicated, but there are specific indications for these, and one should embed medical and conservative management in the treatment plan. Thank you very much, and back to Ruth.
Thanks, Jilesh. Thank you for the whistle-stop tour. That was really interesting and a huge amount of information in 20 minutes. So thank you. There are a few questions. Jilesh, there's actually a couple that I had already put down. I was quite interested. I don't know if you want to answer any of the first two. So there's one around, has COVID or long COVID contributed to urinary bladder problems?
Well, we're just collecting the data, but we certainly are seeing an uptick in terms of bladder problems in patients who've had COVID. It's really in the context of two scenarios. One is that there's a post-COVID neurological sequelae. What we're finding is patients who develop a spinal cord syndrome after COVID. It could be demyelination or inflammation of the cord. Sometimes it's not evident in the MRI, but they clearly have had a neurological injury. The second is more in terms of functional urological symptoms. So this we see in the general urology clinics, where patients report more of overactive bladder symptoms. And so it is something that's emerging, but clearly we are seeing a cohort of patients with functional symptoms in general. So they have presenting with fibromyalgia, chronic fatigue, but as part of that sort of overactive bladder and bladder pain syndrome.
It's interesting. Let me just so following on what you mentioned about the functional side, I know you mentioned that within your slides. And obviously there is about function related to ability, and then there's also functional side where there's been the exclusion of any medical reason. Do you find that gets confused? Because we do find it, I know within certain areas within neurology, there's not necessarily the sort of skill associated to that. I don't know, when we use the different wordings, do you find it can be an issue?
Yeah, all the time, and I agree with the participant who's made that point, because it can be misconstrued as in the mind, and I think perhaps we need to find a better term when we imply that there's a mobility or toilet access issue. I think the original idea was that there's a loss of function from the neurological disease resulting in incontinence, but on the context, in that context with FNDs, we do come across functional bladder dysfunction quite common. So it can be urinary retention or urinary incontinence, and that is something that's poorly recognized, but it is a manifestation, we think, of an FND.
Wow, that's really interesting. That sounds like a whole topic in itself. Thank you, Jilesh. So it's my great pleasure to introduce Colette Haslam. She won't thank me for saying that she's incredibly experienced clinical nurse specialist working in uro-neurology. I think you were working there when I was at the National many years ago. So it's absolutely wonderful to have you here today. Thank you for joining us, Colette.
A bit tech phobic myself. I'm Colette, and I'm the nurse specialist in uro-neurology. So today's talk's really just an overview of what we offer patients from a conservative management point of view. But certainly for a lot of patients, conservative management, is worked in with medical management as well, and looking at the patient as a whole. Disclosure, the board. Okay. So what is conservative management? So certainly we look at the management of options for treating urinary incontinence, and it looks at behavioural issues, lifestyle modifications, pelvic floor retraining, and the use of devices. So that's the type of thing that we tend to look at for most of our patients. And it's beneficial for most of our neurological patients that have urinary tract dysfunction, mainly because when we're looking at behavioural treatments, a lot of our patients, I always say that a lot of our conditions are progressive conditions, and perhaps the abnormal has become normal for an awful lot of our patients. And we need to look at that, because sometimes when we do see the patients, they've had their conditions for several years, for many of the patients. So they've learned to kind of adapt their their bladder symptoms and adapt how they manage their patients. And, and it's always, I think, the main question when you're asking a patient about bladder function is when they say it's normal, you need to be asking them what is their normal, because the abnormal has become their normal, and it's really important. And that's what I always say to most of my, when I'm giving any talks or I'm talking to the nursing staff, to find out what the patient's normal is for them on a daily basis. Okay, so the approaches we tend to look at are for practical advice. We look at bladder training, bladder drill, and prompted voiding for a lot of the patients, because again, sometimes they get into bad habits. And we look at the behavioural training with pelvic floor exercises, with or without biofeedback, and that might involve women's health physiotherapists or neurophysiotherapists. So for my practical advice, we look at the types of fluids, and Jalish mentioned about the use of diaries, and the diary is your Bible, if you like, and really you've got to look at how patients are filling in their diaries. That need to be explained to how they're filling in their diaries, because the diary is only as good as it's filled out, and it actually gives you an awful lot of information when the patients are actually filling it in properly. But I always say to the patient, it's their diary. They need to be right. It's all very well us putting, titles on top of what we're actually looking for, fluid intake and things like that, but they need to be honest with us as well. Sometimes we'll see patients filling in their diaries when they're sitting out and waiting to come in for an investigation or a consultation. And, the best will in the world, you will not remember, what you had to drink and how many times you went to the toilet 3 days ago. So we always, again, the aim of drinking is 1.5 litres to 2 litres. Because again, if you've got a bladder dysfunction, you will reduce your fluid intake. The majority of patients you will talk to will have reduced their fluid intake at some point, be it during the day or in the evening, or in general across the board. And again, that increases the constipation. Again, we look at smoking and we look at weight reduction for some of the patients as well. And that's always a general advice for most of our patients. Okay, so bladder training with prompted voiding. So voiding schedule. So a lot of the patients, when you're filling in your diet, when the patients are filled in their diary, you'll probably notice that an awful lot of the patients go quite frequently. And it's really important that we find out whether actually it's the bladder telling them that they need to go to the toilet, or they've gone just in case. So when we're discussing how to fill in a diary for the patients, many of them will say it's not genuine urinary frequency they've gone just in case. Because if you've got urgency or you've ever had an incontinent episode, you will go just in case. So it's really important that we differentiate that in the diary when we're asking the patients to fill the diaries in. So sometimes, again, when we look at the voiding schedules of the patient, it's behavioural and getting them to increase the timing between the actual voids. And that takes a lot of work for an awful lot of patients because they are scared not to go to the toilet on a frequent basis. Okay, so again, we'll look at the type of fluids and certainly reducing caffeine intake and perhaps the amounts of fluids. I have seen patients in the past, most of their fluid intake is caffeinated basis, and there is some research to show that caffeine can irritate the bladder, and certainly for some patients it's coffee and fizzy drinks. It tends to be their main drink of the day, and that certainly increases any frequency and urgency. Okay. So we also showed the patients how to do, and we discussed pelvic floor exercises. People tend to think this is only for women only, but certainly for men, remembering that men do have pelvic floors as well, and we need to be increasing the tone of the pelvic floor for relaxation and muscle contraction. So from a continence advisor's point of view, we tend to teach a lot of the basic pelvic floor muscle exercises, and it's actually showing patients where the pelvic floor, a lot of patients are not aware actually of their pelvic floor muscles and what muscles to actually exercise. So a lot of it is education around the pelvic floor contractions and relaxation and how to do that. And there is videos that are available for that to reiterate any of the advice that you might be giving to the patients. Biofeedback and neurostimulation might be involved as well, and you might want to involve your physiotherapy colleagues in regard to that. Okay. So it's an effective option for the neurogenic bladder dysfunction, and certainly when we're considering these options, we should be looking at it using it alongside any anticholinergics or anything else you might be deciding to use for your patients. And certainly it's really important that, for a lot of your patients, this would be the basic starting point for advising your patients if you're in clinic and you didn't have any other options in regard to further examinations such as bladder scanning. But you would have to, your first port of call for a conversation would be on behavioural training and fluid intake for your patients. Okay, so the use of continent containment appliances that we have, there's many out there, and I always say there's more to continence assessment and more to continence treatment than pads and convenes. So really this is the things that you need to be looking at, and that's why you should be referring to your continence service, because continence advisors have a wealth of knowledge in regard to the appliances that are actually available for the patient on an individual basis. Okay, so the things that we consider when we're actually seeing the patient, certainly, there's different appliances for male and females, and it also depends whether how ambulant the patient is and how they go about their, if they're working or if they're at home, and some of the, especially from a carer availability point of view, who's actually perhaps helping the patients with any appliances that you might be considering. For a lot of the patients, you're looking at cognitive issues and eyesight and dexterity to actually see if they can actually use the appliance that you might be actually suggesting to them. Okay, so what's available? There's lots, as I said, there's lots of different appliances out there and on the market. I do suggest to most of my patients that they work with the continence nurse. There's a lot of appliances that you can buy, that patients will buy online, and some of them are quite effective, but perhaps they're not using them to their best, the best ability. So it's really important that we look at that. When we're assessing our patients, we certainly look at their neurological condition, because the appliances, again, that you might suggest to your patients might change over time. Bladder dysfunction might change over the time, and their lifestyle and how they, as I said, if they're out working or if they're busy, we had the case study earlier on, it was a busy mother, that was out working as well. So certainly, type of appliances that she might want to use might be different to somebody that was quite elderly. Yeah. So I'm putting pads in here mainly because that's the thing that you will see with most of your patients. And chances are they have gone out and bought their pads and they have not been assessed for the use of pads. There's many different types of pads, and obviously I could talk about pads for well over an hour, if not 2 hours, just talking about the different types of pads that are available. But the pads are only as good as you're assessed your patient, and they come in all different shapes and sizes. So it's not one size fits all. So it's really important that the patient, that somebody does discuss with the patient what type of pads that they're actually using, and are they actually continence pads. I've put sheaths in here in regard to the use of Uro sheaths, and there's all different types and sizes for this. And, if somebody's using pads or a sheath that you come across and they haven't been assessed properly, really, these are containment, they're for containing any incontinence episodes. They're not actually a treatment option, they're a management option for keeping the patient dry. So really, if somebody is using sheaths or pads, we should be assessing our patients to find out why they're actually having incontinence episodes in the first place. Again, sheaths are only, they're only as good as they're put on, and they're not suitable for everybody, but it is important that the patient is assessed if they're going to use a sheath. And, I always do say when I'm, talking about sheaths that there's not many people that we do have to measure the penis in regard to the proper size for sheaths, and not, there's an awful lot of people out there that are using sheaths that do not fit, and that's why they're not suitable for a lot of the patients and they don't work. So I think, again, it's referring your patient to a continence service that can assess your patient properly. Okay, there are female devices out there that are perhaps not used as often as they perhaps should, but certainly they tend to be mainly for stress urine incontinence. However, there is some that are available for mixed incontinence, and they tend to be used more for ladies that are perhaps a wee bit more active. There is obviously there's internal urethral devices that are available, and internal vaginal devices. So again, it's assessment of your patient to see which is best for them, and some ladies might perhaps be referred on to Women's Health in regard to this. So the other thing that, like our lady in our case study had a touch of hesitancy, and a lot of your patients will say that, they've got frequency and urgency, and even when they've got the urgency in getting to the toilet, they feel that they can't actually, initiate the actual void. And that's quite common for quite a few of our neurological patients. Many of your patients, if on questioning, will say that they use Creed or Valsalva movements or a variation of, and in the main that we do not recommend that that's what they actually do. There are many trigger techniques that some of the patients use, and over the years I've learned lots from my patients about how they actually trigger their bladders to actually initiate a void. And certainly for a lot of women, perhaps it might be urethral stimulation by just touching the urethra, and a lot of the patients will initiate a void with that. Some are just standing and sitting down, and perhaps just some gentle movement about will get the voids commencing for them. But that's a discussion that we have with the patients. Another device that is available is a Queen Square bladder stimulator that we studied in 1997. It was a paper we did, and it certainly is a small handheld vibrating device that we use or we offer some of our patients that have an interrupted void with a smallish residual. It's not suitable for people with large residuals, and certainly we found with some patients it helped the detrusor pressure increase and the residual reduce. And we certainly still offer it to some of our patients, but by no means does it empty the bladder completely. The only thing that will empty the bladder completely is intermittent self-catheterization, and certainly is, the NICE guidelines, it's the gold standard of management of urinary retention. And really for many of our patients over the period of time that they will have, that we see them, we do teach intermittent self-catheterization, and it tends to be used for frequency, urgency, and retention of urine. We know that it will reduce urinary frequency, it will reduce urgency, and it will reduce incontinence episodes. At times, this might be just by the use of the catheter. However, they might require medicinal help as well. Many of the patients will reduce their UTIs because they're not retaining the urine, and that's for a lot of the patients, that's the mainstay of how they actually do reduce the urinary tract infections. Many of the patients have fatigue due to the frequency of having to go to the toilet, especially during the night. And by offering them self-catheterization, this fatigue reduces quite significantly. It also gives increased confidence. A lot of people, when you're discussing with your patients the effect of their bladder on, on their day-to-day life, and very many of the patients will say to you that they don't go out or they don't, participate in any family activities. A lot of them have perhaps stopped working due to their bladder. So by increasing, management option of the bladder, you actually give them back their confidence to go out and be, participate in day-to-day life. And many of the patients will say to you that actually, out of everything that they actually do for the bladder, it's learning how to self-catheterize has been the best thing that they've ever done. And, you will hear that from many of your patients. Again, looking at the renal function, for a lot of the patients, it will help with that if they have any issues with higher pressures. Intermittent catheterisation is not suitable for everybody, and patients do require to be assessed quite significantly. We do look at positioning when we're teaching intermittent catheterisation, and certainly dexterity and cognition are probably the mainstays of how we assess our patient. And for some patients, intermittent catheterisation is not suitable due to anatomical reasons, and that could be either penile or vulval or vagina. From a psychological factor, the main reason why the majority of patients will not be keen on intermittent catheterisation is usually due to the anxiety and the stigma and the fears, because a lot of the patients will have perhaps heard of it before, and it's explaining to them properly exactly what intermittent catheterisation is about. But for the majority of patients, with good assessment and good discussion, they will actually come round to be taught the self-catheterisation. There's many different types of catheters out there. Coming from a neuro background, I do like to think that I'm probably quite good at teaching intermittent catheterisation after all these years. And, we never look at somebody and think they'll never manage. We always try to teach everybody how to catheterise. And I think, most people should be assessed to their ability. I'm always surprised, I'm still surprised these days looking at patients thinking they'll never manage and they still manage. So I think it's really important to refer your patients on to somebody that actually, that will offer them the time to go through the catheterisation. And sometimes we see somebody once, or we might see them several times. And again, as some of the neurological conditions change over the years, you might have to see them again for assessing if they're actually continuing to manage to do the intermittent catheterisation. And that's where the benefit of all these different types of catheters are, for use of, and, when we're actually teaching the patient over the years, we might have to change the type of catheter that they actually use over several years. And at times, some patients will use one during the day and they'll use one in the evening. And again, it depends on their lifestyle and how they, how they want to work with the catheter. And it's working with the patient in regard to the type of catheter and how often they perhaps need to do it. Okay, there's lots of different appliances out there to help with the intermittent catheterisation, and that's what I mean by assessing the patient properly. And usually, for an awful lot of the patients, they will manage the intermittent catheterisation, and it will be very beneficial to them long term. I'm putting indwelling catheter in here, and I always put it at the very end because I think there's lots of things as Professor Paniker said as well, lots of difference in the medications. And again, from the management options for the patients, we look at indwelling catheters that, the kind of, looking at that as perhaps our last choice. For want of a better expression. But certainly, for many of the patients, having an indwelling catheter will give them a quality of life that they would not have due to their incontinence. And many of the patients won't go out, especially if they can't manage to do the intermittent catheterisation. And perhaps they're thinking, oh gosh, that's it, I'll just stay at home. But certainly indwelling catheters can give patients a quality of life and a lifestyle that they might actually benefit from. So we shouldn't actually, say that indwelling catheters are not, suitable for everybody, but they do need to be discussed from a long-term point of view with your patient. And certainly suprapubic catheterisation tends to be the catheter of choice. I've put this slide in from a catheter valve and catheter bag point of view, mainly to say that there are lots of different, again, appliances out there for patients. Catheter valves are not suitable for everybody, and certainly from your neurological patients, the patients have to be assessed for the use of the valve. And we see a lot of patients with valves put onto their catheters, and it can cause some discomfort, and it can cause some worry for the patient. So again, it needs to be discussed with the patient. Lots of different bags for the different lifestyle that the patients have as well, especially if somebody's playing sport or if they're wanting to wear a pair of shorts and things like that. Again, it's referring to your continence service in regard to that. Okay. It is a multidisciplinary approach, certainly from a medical point of view, but certainly, you know, I discuss some of our patients with physiotherapists and occupational therapists in regard to hand function and appliances. So sometimes we really do have to involve everybody if we're to get the correct appliance for the patient. Okay. So I hope I've just kind of, you know, given you some you know, indication of what's available out there. There's many different, you know, obviously looking at the management options in an individual point of view, there's, you know, a lot more available, and there's a lot more discussion around it, and it's how to assess your patient properly, and that's kind of things that we would go into in greater detail if we had more time today. So looking at from a neurological point of view, it's remembering that your patient's needs will change, and it's having assessment and not discharging your patients in regard to that, or the fact that the patients will have access to a continence service, and that's kind of like, you know, our job sometimes is as a signposter for our patients to make sure that they get the best care possible. Okay, thank you.
Thank you very much, Colette. You know, excellent to talk through that. And actually, one of the things you said, which really resonated with me, was about the abnormal becoming normal. And I think we see that with patients in clinic all the time, things that have been going on that they haven't actually shared with us. And that actually brings us beautifully into our next part of the webinar, because actually Sue Thomas will talk us through the NHS transformation agenda and how this applies to bladder and bowel management. And I feel this is hopefully very much towards leading us towards supporting self-management, so that hopefully patients don't sit at home with these symptoms and would rather talk about it. So I will hand over to Sue.
Good morning. My name is Sue Thomas, and I'm going to be speaking to you on this webinar around the NHS transformation agenda and its relevance to bladder and bowel management. I'm just going to give you an update on the NHS England and NHS Improvement Neuroscience Transformation Programme that sets out the future commissioning models for neurology, and look at the implications of those for neurological conditions and bladder and bowel services, and also highlight the relevance of the neurogenic bladder to services in the devolved nations as well. So in terms of the agenda, we had the Getting It Right First Time programme that ran for a couple of years, and the report was published in 2021. Geraint Fuller did that review along with Adrian Williams and highlighted how current neurology services were working. We're now in a process of moving towards transformation, and that's really the enactment of what came out of that GIRFT report, looking at what's been wrong with neurology services and how we can improve them for the future in the new landscape of integrated care systems. So there is a real emphasis on population health at the moment for transformation, opportunities and levers that will create service impact and improve services for patients. And the NHSE is building a comprehensive integrated care board toolkit that's being tested by Pathfinder sites this year, ready for publication in 2024, so that we know how ICBs need to work. It's looking at what the levers are and the barriers that remain for whole pathway integrated commissioning for neurology services, and also looking at shared issues like workforce rehabilitation and new service specifications. And it's setting up neurology networks for the delivery of delegated specialist care. So by April 2024, all integrated care boards will a suite of necessary tools to enable them to move towards a whole population management approach, and that includes a neurology dashboard. And the issue with that is that problems like bladder and bowel dysfunction will be highlighted within that in terms of data. So at the moment, ICBs are working towards a legal framework that's going to be in place by 2024, and it provides us with an opportunity to join up the fragmented commissioning pathways that we've had in the past for bladder and bowel services to improve management. And we've got a new neurology model, and as I said, it's going to focus on population-focused delivery. So it's looking at how many people are affected by bladder and bowel problems, and at what cost is that to each ICB. It's going to be looking at managing need, not just demand. So the neurogenic bladder is a huge problem for many of our patients. This is the neurology future commissioning model and how services are going to work. So on tier 1, we've got primary, community and secondary neurology services. Tier 2 is the specialist clinics that are delivered by a DGH or in tertiary settings. And then the tier 3 is highly specialised services. And I guess the message here is that everybody needs to be bladder aware. Everybody needs to be able to manage patients that have got bladder problems, regardless of where they work in the workforce. It's not just a specialist issue, it's down to everybody for the future. We've got transformation pilots that are testing this out, and some of the conditions that are being tested in those 2-year pilots are Parkinson's disease, MS, epilepsy, neuromuscular disorders, and then functional neurological disorders. And they'll look at how care is going to be provided across the whole care pathway. So it's important to be aware of that, and particularly around the neurogenic bladder, how we might get involved in things like these transformation pilots to improve the situation for our patients. This is a kind of a schematic around what integrated care will look like. And we've got the patient in the centre, and a key issue on this is around supported self-management. So it's about patient education, it's about lifestyle, smoking, diet, in regards to bladder management, things like caffeine reduction, exercise. It's around trying to make patients aware that they may experience bladder problems and getting them to seek help when they need it, not just hanging on because they've got a problem and not being afraid and being afraid to actually speak to somebody about it. It's also about, in primary and community care, making sure that our community workforce is upskilled in order to be able to manage patients appropriately before we actually move them on to specialist care. So it's looking at that specialist integrated team that can support patients from self-management through to actually getting any help that they might need. And I would suggest that at the moment our workforce isn't skilled enough to facilitate this. There is a wider agenda around the neurogenic bladder as well, and the integrated care boards are particularly interested in things like gram-negative bloodstream infections, antibiotic resistance, use of A&E admissions for UTIs particularly. There is a whole focus on menopause and UTIs, and then things like adequate hydration for those that are at risk, because many of our patients that have got bladder and bowel problems probably don't drink enough so that they don't have to go to the loo, and then they exacerbate the problem. There's also a big impact on the workplace and social life for younger people if they do have these problems as well. And I've put here on the right-hand side one of the documents from Wales. Wales has actually prioritised bladder management, bladder and bowel management as a strategic priority for 2023-24. And so you can see the importance that's being placed on the management of bladder and bowels by the devolved nations as well. So some statistics here really around the situation in terms of bladder and bowel issues post-COVID. UTI has been a major cause of inappropriate admissions, and many people were trapped by continence issues during COVID. There were 177,000 admissions for UTIs before COVID, and it's expected that there's going to be a significant rise again as a result of people's failure to seek help. 19% of all hospital-acquired infections, healthcare-associated infections, are for patients with catheters. 300,000 patients contracting healthcare-associated infections in NHS hospitals each year, and particularly UTIs, catheter-associated UTIs contributed to that. In 2018-19, there were 177,000 admissions relating to 147,000 patients. So you can see what the size of the problem is here. It's huge. And if you look at one area, and this is multiple sclerosis, we had 26,820 hospital admissions alone for MS in the year. This data was published in 2020. At a cost of £83 million. And a huge amount of that, nearly £8 million, was as a result of urinary tract infections, and £6.9 million as a result of bladder and bowel related admissions. So costs are huge here. It's really important that we recognise what those costs are. One of the big drivers at the moment, of course, is the operational planning guidance. This is the operational planning guide that we have at the moment, 12 priority areas. One of the big areas is to reduce urgent care, reduce bed occupancy by 92%. And again, you know, one of the reasons why our patients with neurological problems are going into hospital is a result of bladder and bowel issues. So we've got some of the national guidance there that's supporting us in terms of delivery of services. I think just in terms of the transformation agenda, nothing is going to happen at a locality basis unless we've got a pathway approach to care. And this is the pathway that we developed when we were updating the consensus guidelines for the management of multiple sclerosis, bladder and bowel in 2021, published in 2022. And you can see here that we've got a pathway here that starts with education on lifestyle, and then ensuring that patients bring bladder and bowel up when they have their annual review with their MS nurse. And if problems arise, then they can seek advice from their MS nurse or their GP. But of course, they are only trained to do so much, and so that might require liaison with bladder and bowel services and their support in order to manage patients appropriately. So I think that, you know, it's really important that our workforce is upskilled in order to be able to manage the neurogenic bladder. So just in summary, in this rapid 10 minutes around transformation, I think we've got an unprecedented opportunity to address the neurogenic bladder. Integrated care is now a priority for transformation, and this means that the whole workforce needs to be bladder aware and have the skills to identify when someone has a problem. A pathway approach is essential, and the way that we're going to actually address this is through education, and education is going to be key to ensure competency of our workforce for the future. Thank you very much for listening.
Thank you very much, Sue. And just before we go to the sort of question and answer, I wondered if we could just quickly go back to the case study that I mentioned at the very beginning, and just ask both of you how you would go about managing this lady. Jalesh or Colette, who would like to go first?
If I was seeing her, obviously, the main thing I'd be looking at is a Uroflow. For most of our patients, it's a diary, Uroflow, and bladder scan, because obviously you cannot really manage a patient properly without knowing if they're actually emptying their bladder properly, because that's the basis of most of your treatment options is a bladder scan and finding out how well they're actually emptying their bladder. From there, you can assess your patient as to whether it's behaved, and by using the diary and by talking to your patient, it's looking at it then, is it behavioural, and looking at, obviously the drinking and their, and taking into consideration, obviously, any constipation or anything else that's actually in their daily, life that's going on with them. I would always start with that if I'm seeing the patient initially. And obviously, it's depending what they've actually tried in the past, because sometimes they have seen a GP and perhaps they're actually already on medication before, perhaps you actually see the patient, and they might have stopped it, or they might still be taking it, and that might be exacerbating any issues that they've actually got as well. So that's the main thing that I would say, Jalish, we would see from an initial first line management. You'd be looking at the basics firstly with your patient.
Jalish, do you want to add anything?
Well, you know how it is in NDTs, we always agree with the nursing.
Yeah.
But I think
Good answer.
But I think I would add to that from this history, I would strongly suspect that she is probably retaining urine just because there are UTIs, hesitancy, intracranial stream, and there's also constipation. There might be sort of incomplete rectal evacuation that might be contributing to the voiding dysfunction. And so certainly we would explore those aspects, conservative management, before we would even enter a discussion about pharmacological and other treatments.
Thank you. Now, I'm conscious that we do want to finish at 12:30, so if it's okay, I think we'll probably answer one or two questions, and then we will answer the rest online. We do have a very exciting announcement shortly, so I want to make sure we have time for that. I guess one of the questions, and there was a bit of a theme coming through, you were talking about neuromodulation with PTNS, TTNS, etc. Do you think that this is widely available across the NHS? Is this something that outside of the specialist centres there is access? And if there isn't, do you have any idea if there is change afoot to make this more of a or less of a postcode lottery?
I think sadly not. I think that it is very patchy in terms of its spread. And I think there are different reasons for that, but it is delivered by different services. In some areas it's urology, some areas it's physiotherapy. I think with PTNS, it's very resource intense in terms of individuals getting patients through the door, whereas transcutaneous, I think, could be potentially a game changer. We just need to show how to use it, perhaps either face-to-face, ideally, but then the patient can deliver this at home. Sacral neuromodulation, I think perhaps in select cases, I think there was a question about sacral neuromodulation, but certainly not for everyone. And there was a question about MSA, and I would say that's perhaps a group we would not offer sacral neuromodulation for.
Okay. And the other one, just quickly, actually, there's a question around should we, and it's quite political, so I think it's appropriate for everyone, should we be suggesting the use of D-mannose and cranberry extract for UTI prevention? That's probably a huge one, but do you have any top line?
I would say yes, yes. And we do suggest it for many of our patients, and I think, we didn't bring in diet today, but, when we're looking at our fluids and we're looking at, supplements for some of the patients, but, there is some studies to show that, especially D-mannose helps with neurological patients. And it's certainly something that we do offer, or we suggest to the majority of our patients as a very first line management in regard to UTIs.
Okay, thank you, Colette. Sorry, Tilesh.
There's 2 points. One is that there is research to support their use, particularly with D-mannose, and to an extent cranberry extract. Number 2 is to say that it's specifically for preventing E. coli related infections. So if it's due to other bugs, then we would want to explore further, and these agents are probably not going to be effective for those.
Okay, thank you very much. I think we'll answer the rest of the questions online. So we just thought we'd quickly mention there is lots of other Neurology Academy education through there's over 14 different academies. There is webinars online coming up, there's masterclasses, and also there is online education. So we have online education. The next slide shows our health and wellness program. So this is something for you all. So we have lots of education which helps educate you to look after the people that we look after. But this one is for you. This is helping you to look after yourself, especially after the last 3 years. I will hand over to Jilesh.
Well, thank you, Ruth. Well, so I'm pleased to report that there's a new addition to the Neurology Academy. And so I suppose we can consider this event as a launch of the Uro-neurology Academy. It's perhaps the first time in the world that there's an academy dedicated to neurogenic bladder bowel sexual dysfunction. And that's precisely the objective of this academy. It is filling a gap in our understanding, awareness, and the practice of the management for these symptoms. So essentially what we're trying to achieve here is to establish a platform where high quality education is delivered around the bladder bowel sexual problems that individuals with neurological disease experience. So how to assess, how to manage, and provide it in the holistic framework of pelvic visceral dysfunction, but also in the holistic framework of other neurological symptoms and disabilities. So this is quite an exciting development, and I would like to say that there will be to launch this as a masterclass that's being planned towards the end of the year. So you can see the dates on the screen. The first week of December in Sheffield, and this masterclass is actually the program is sort of being designed around case vignettes. However, it's going to also have science involved, so we'll be sort of presenting the science that sort of backs our understanding of the management and treatment of these. So we start about sort of the neural control of bladder dysfunction and how that's relevant to the practitioner, but also in terms of how to assess bladder and dysfunction and management strategies, many of which that you heard this morning. There's also about sort of complications such as urinary tract infection, prevention and management, which sort of resonates well with many of the comments in the chat box. We'll also be sort of in this masterclass addressing sexual dysfunction, something that's sort of not really touched upon, particularly in women, but also in men with neurological disorders. So an exciting faculty is what's promised, which is going to be multidisciplinary. So you have medics, you have nurses, you have therapists. And so we would like to invite you to the website, where I am told that the registration is now open. There is a snippet of the program that's there. Have a look, and we look forward to seeing you in Sheffield in December.
Thank you, Jilesh. I would just like to add there are only 30 places available. So if you are interested, I would get on and apply. So I just would like to a big thank you to the speakers. Thank you so much, Jilesh. Thank you, Colette, and thank you, Sue. And thank you to Neurology Academy for arranging this webinar. And we very much look forward to those of you who apply to seeing you in the masterclass in December. Hope you've had a good webinar. Bye.
Thank you.